get to that point from a timeline standpoint? Are there steps that we need to take in the interim, and what should we as a foundation and then as a group of families who are motivated to try to help find treatment and a cure be thinking about? I'll open that up as a start question for anybody who'd like to weigh in. I've stumped experts.
Can you repeat the question again?
Yeah. So it's about future research, what we need to be thinking about, and what sort of a timeline we're thinking about from potential treatments and then new treatments and a cure for this disorder. And does that help rephrase the question?
Yes,
Make sense?
Well, I think we all wish we knew the answer to that question. This is really a very challenging disorder. I'm a pharmacologist. I like, drugs and finding ways to treat people with pills that they can take every day or whatever. But it's a very complex system. The G-alpha-O is regulated by 200 different G-protein coupled receptors. A couple of the drugs have some benefit, but they have side effects and they have limited efficacy. Frankly, I think the way to go is ultimately going to be molecular and genetic therapies. As much as I'm working to try to find existing drugs or new drugs that will be beneficial and improve things, I think the genetic and molecular therapies are probably going to be the best ones, and then how to best get there in the fastest and safest manner is going to be a big thing.
So I'm an engineer, not a pharmacologist. So I think we pair well together. But and so I tend to think more on a systems level, and that's my interest in DBS and kind of related technologies. And I agree that I think that the ultimate end game should be molecular and genetic. Target something that's very, very specific to the protein that's not functioning correctly. I think it's going to take a little while to get there, because before you can do that and before you want to go changing things in the brain, you really need to make sure that you understand what exactly is going on. Because the last thing you want to do is introduce a irreversible gene therapy that does something that you don't want it to do. And so I think that while, part of what I see as, my role here and, the role of some of the other clinician scientists is to, okay, how do we maximize both the knowledge of the disease and how can we best study what treatments we have right now, such that we can maximize the quality of life and best treat our patients while we're working out the molecular biology and pharmacology of all of this.
So I'm going to say what Amy and Rick just said, but differently. So how do we get there? I think we get there by making sure there's communication between the families, the doctors, and the basic scientists. So we get there by growing the Bow Foundation and understanding the importance of it. And it's important because it brings great scientists like Rick and Kirill here. It brings young epilepsy and movement disorder doctors like Amy and Jojo here. We need to create an excitement. We need to keep people interested. Science is big. There are lots of questions that can be asked. We need to create that buzz to keep GNAO1 at the forefront. Because it is a rare disease. It's only 100 or so people at this point. There are lots of disorders and syndromes out there that are more, and there's money going towards those. We need to create a buzz. We need to keep people interested. We need to be patient. Science is hard. If it was easy, there'd be a lot more scientists. It is hard. As Mike talked about earlier today, it took him a year to get to a point where there's data. It's not a lot of data, but it's the beginning of data. And to create data, to create good data, takes a lot of time. So we need to be patient. We also need to be aware of everything that's going on around us and look at other diseases, such as spinal muscular atrophy, Duchenne's. Look at where their solutions are coming from, and then testing those solutions in this disorder. Does it make sense to go that way? Creativity always happens in the cracks. We need to be looking in the cracks as we look towards that cure. And as we look towards the cure, we need good doctors. We need to educate good doctors to make sure that they remember that your children need good care now as we wait for a cure. And so we have to educate them on how do we provide good care. Amy and young epileptologists need to be out there saying this is how we best treat these people in 2019, 2020 as we look for a cure. So I don't think I said anything different than Amy and Rick. Just want to emphasize that this is the right way, this is the right path to be taking.
So I hand up, James, did you ask for a follow-up?
On the good doctor side, I mean, how do we get our regular, the people that we're seeing weekly or monthly connected with the knowledge base that's out there so that they can effectively implement this stuff?
So how do I define a good doctor? I define a good doctor by somebody who is more than willing to listen to the parent and be educated by the parent. So you can push them. Tell them what you learned this weekend. Teach them. Make sure they're open to hearing what you learned this weekend. How do we educate them? We publish the studies that we're doing and make sure that it gets out there. And make you aware that we've published it, so you can say to them, hey, did you see that paper? So it's just like we're here today. It takes a community, and a good doctor recognizes that and recognizes that you're part of that community, and that you probably know a little bit more about GNAO1 from attending here today than they do.
I was just going to say that's one of the goals of this bigger natural history study effort is to develop a set of people who have the expertise that can be a resource for your providers closer at home to reach out. And that not only includes doctors, but that includes physical therapists, that includes occupational therapists. And it's not just me and my team here, but the different, epilepsy researchers around the country as well. And, we don't quite have the infrastructure quite yet, but this is part of the effort to build that. And know that we are publishing and we are presenting. I just presented in Barcelona at the International Pediatric Movement Disorder Symposium. At Child Neurology Society, we gave a talk on how to treat inherited movement disorders. So we are making that effort, but it needs to be a sustained effort.
I'm curious for your take, Mike. In your presentation, you walked through, you got to the point where you created this stem cell line that can go any number of ways, but each of those ways requires funding. And how do you, as a researcher and scientist, decide which path makes the most sense? Because I know what I know and I don't know anything better. And so we've got to lean on the experts that are working on this. So from your perspective, how do you decide which path to go down next? And how do you coordinate with your peers in the industry to make sure that you're not stepping on toes and what you're doing supports the work that's being done elsewhere?
Yeah, I think that's the right question to ask. So, this meeting is actually fantastic because just talking with Rick and talking with Carol, and it really helps me choose amongst various ideas that I might have in the first place. But, bigger, through the Bow Foundation, I've been connected with other folks that are interested in the same line of research, right? So, I've created lines from 2 patients, but every patient could be different, as we sort of alluded to, right? The different genetics. I think that's the power of the IPS model, is that it's not just that one gene that we're studying. We're studying the entire background of the individual, and it's more common than it is otherwise, that the background actually matters for a lot of the important features. Certainly, which drugs work and which drugs don't work, and that sort of a question. And so I think we're doing things the right way and connecting with the other folks. And so Max and I were talking earlier about his physician in Italy wanting to sort of pursue this kind of research, and keeping all of us connected with each other is probably one of the most important things to be doing.
Dr. Newbig, anything to add from your perspective?
Well, I absolutely agree that getting people together and getting them to talk, because there are lots of ideas, and oftentimes the ideas sit in someone's lab for 2 years before they see the light of day. So we probably started our genotype phenotype studies, on, say, January of 2016, and then submitted it in January of 2017. It didn't get published until December of 2017. So there's all these things going on where people know bits and pieces of the picture, but it doesn't get out into the literature until much later. So getting people together, having them a chance to talk. So like, obviously, Dr. Matemyanov and I have somewhat different takes on what the different mutations mean, and that's really important for us to think about it, talk about it, be able to move in different directions, and try to maybe resolve some of the differences. There are different systems, different interpretations, and to what extent can we understand how that affects the biology of the protein and the effect on pathophysiology. And some of these questions are really important. So the whole idea of gene therapies, one strategy, if you have too much function, which is sort of the model we've generated, if you have too much function, then you want to knock that down. If you have too little function, you need to bring it up. So resolving some of these questions where scientists have different systems and different interpretations, getting people together is really important. So I think thinking of a way of potentially expanding the number of scientists that come to a GNAO focused research meeting would be valuable. There are these R13 grants that NIH has that will allow you to have perhaps a bigger meeting that includes a greater number of scientists in the GNAO1 community. I think something like that would really help us move forward and help us think about what's the best path forward on those things.
Any other comments from two other panelists on that?
We could potentially tap into this ever-growing network of genes that cause epilepsy and movement disorders, and
Yep.
Any other questions from the audience? I've got a few others, but I want to give you all a chance to ask questions you've got on research. Yeah, Elizabeth?
So I think I speak for all of us probably when we all want an answer for our kid like right now. And Dr. Griffin, you literally said we have to be patient. But one of the things that I wrote down while you guys, while Dr. Griffin started talking was what's the biggest hindrance and what can we do? Because I personally feel super helpless when, that's why I try to email doctors and go to every research clinic I can, because I'm trying to move along whatever I can. I'm also crazy about trying to raise money for the Bow Foundation. What's the biggest hindrance? Is it time? Is it money? Like, what can we do?
Do you need more DNA samples? What collects it? What do you need? Yeah.
Is all of the above acceptable?
Yeah, so I think right now, as I think we've talked about, this is a complex mechanism. The GNAO1 has a fairly complex mechanism in the brain. We don't necessarily know which brain region is it. Is it specifically the dopamine areas in the middle of the brain, the striatum? Is it the cortex? So there's a lot of complexity, and I think one of the things that slows things down is not necessarily knowing answers to some of those questions. And so I think clearly, money does help. It still takes time. Even if you have money, it takes time to answer some of the critical questions that we really need to know answers to. But I think, the other thing I've talked to a couple parents about is I don't know to what extent you have leverage over your people in Congress, but if they would say double the amount of funding at NIH for rare diseases, they're not going to earmark a GNAO1 bill, but they might earmark a rare disease bill. And if they could double the amount of funding for rare diseases in NIH, that would probably help all of us be able to have a better chance at getting funded. And the amount of money, if you get a NIH grant, that's like $3 million. over 5 years, but it's $3 million. And so what the Bow Foundation is doing is spectacular, and it's really helping us get going and get the pilot data we need to be able to get NIH grants, but you really need that next level of funding to move things fast.
So,
right now you need funding, right? That's what you're saying, like right now?
Do you need funding right now?
Yes.
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 Yeah.
Like, I mean, just even thinking about like the clinic next year, and if you looked at what Dr. Hershey presented and, all of these tests that they were doing and like even just thinking about, okay, do we want to try and do some MRI scans on kids maybe who can lay still? I need to get the updated figures, but, time in the research scanner is like $500, I think it's at least $500 an hour. So what we did in this clinic was, okay, what can we do with, with a set amount of money, but maximizing what we can get, but we can't get the expensive tests, and it does limit the number of people we can have, so yes, we also need people, we need, the more researchers that are working on this, the greater chances that we're going to make progress faster.
Yeah, I also want to add that GNAO1, we shouldn't sit in isolation. There is the Rare Epilepsy Network, which Emily has made inroads in connecting with. So just as there's power in numbers here today, there are more numbers, there are more rare diseases out there, and as we team or you team with them, then we can start lobbying the NIH to say, hey, this is important, we need money. And NIH grants are where the majority of the money is. And so the more money we can get into the budget for NIH dollars, the faster all science will progress.
James, I think I saw a hand from you.
Yeah, aside from having money available to entice researchers, what are other ways to get researchers interested? I mean, how did you guys come to, we heard your story, but how did you get, what were your stories and how can we access more?
Yeah, so you could sponsor fellowships. So like right now, like to do a pediatric movement disorders fellowship, you kind of have to piece it together. There's not really a mechanism to pay for it. So you kind of have to scrounge and get some research funding here and pay for that, and kind of forego funding from your clinical training, and so sponsoring a fellowship to train somebody in movement disorders or in epilepsy, from the foundation, and with that could come, dedicated research time to so that they're becoming clinical and research experts.
Basically, the same thing is absolutely true in basic science. So Jade, the grad student in my lab, did a great job and really touched virtually everything, because she was the only one in my lab working on this. But she's going to go off and work on another gene, because she's doing a postdoctoral fellowship where she does her training. Having a postdoc who comes in to work on GNAO1 in my lab rather than a PhD student, they will probably build that expertise, and then they will probably stay in that, because typically the trajectory is in PhD, you learn your basic skills. In your postdoc, you build your program that you're going to take with you as a faculty member. So postdoctoral fellowships to support someone to jump into GNAO1, just like the clinical fellows, would really help build research people where that would become their focus. So that's a really powerful way, and it's, it's moderately expensive, but it's not as expensive as a big NIH grant.
What's a dollar figure on that?
Probably 80,000, 60,000, 70,000.
A little bit more for the
Clinical.
For the clinical.
So,
Per year.
Per
Per
year.
year,
Per
yeah.
year, yeah. So, in the epilepsy community, we have two organizations, the American Epilepsy Society and Citizens United in Research for Epilepsy Cure. Both those organizations have targeted their research money towards postdocs or junior faculty. really hoping that we will bring people into epilepsy research, and that the younger we can grab you and create your career in epilepsy, the more likely you are to continue your research in epilepsy. So, if we're thinking about how do we bring scientists in, bringing junior scientists in who have many years of productivity left is a good place to target. And these are people who are very excited when they get $50,000 or $60,000 for a year instead of $3 million for 5 years. They're still, and they can do a lot for $50,000 a year. So it is a good place to target money as you begin to try to attract more people in, and then recognizing that we do have senior researchers who also have an interest in there. So, helping them to fund junior people in their lab is a good place to target money.
Howard, can you-
Yes.
So the Bow Foundation actually is a part of the partnership with AES. Can you explain that a little bit?
Yeah, so at AES and through the Epilepsy Leadership Council, which is an umbrella organization of the Rare Epilepsy Network and many other organizations that are helping to move epilepsy research along. Yes, yeah. So Bow Foundation is certainly an important part, as are a number of other family-led groups. And so every year, AES has a call for applications from junior investigators, postdocs, and what we do as the AES, the American Epilepsy Society, is we provide the scientific knowledge to be able to review those grants and say, is this a good grant or is this a bad grant? Is this worth funding and investing in, or would we say this idea still needs some work? And so what Bow Foundation has told the AES is that if there's a really excellent application that's deserving of investing, that Bow Foundation will help the AES to fund that award. So again, what's our role is we as the Bow Foundation, me as a epilepsy leader, need to make sure that my colleagues know that there is GNAO1 money available and to get in a good application to the AES when we call for applications.
I think also one thing that that this type of meeting is helpful for and is building our network around the world. And we've been talking about, potentially setting up a second site for this kind of natural history study in Europe. Hopefully we could do it kind of in combination, but if we need to have to be two separate studies, then we can do that too. But such that we have the infrastructure, so that we'll have the infrastructure in place. Once we are ready to do large-scale clinical trials, we will have the numbers that we need to do effective studies.
Tori, you had your hand?
Yes, so in Kansas City, I know we're, Children's Mercy's building a brand-new genome center, and they're trying, building a huge building, and they are wanting to take on all these projects and be known as like a centralized genome, for rare diseases. And so I'm just trying to figure out how can we try to leverage things like that, where they are already getting a ton of money to do that. They need to find projects to do there. So how can we leverage when places are doing that?
So they first of all, no, they are not alone in that. Inova Hospital
Yeah.
in Northern Virginia has spent a lot of money.
Right,
There are
right,
lots of
yeah.
places. Again, what you need is a champion. So you need somebody in Kansas City who thinks that this is worth their time and effort to get in there. And so we certainly should be looking, or you helping to look to see what is it that they're interested in really, and where are they putting their money. But knowing that those resources are available are certainly important, and to see exactly what they're doing and how that can inform what we do is the way to start.
And if it's really a kind of genome-specific type of endeavor, pushing them to sequence kids with epilepsy and movement disorders where insurance is not paying for it. That's one of the reasons why there's 5 patients in Kansas City.
Right, because they are.
You know, so the more diagnoses that we will have, the more numbers we'll have, and then the more information we'll have.
Although even there, Invitae is now doing gene panels for free on any new onset epilepsy under 5. So we're going to start getting data quickly on lots of rare diseases as companies are willing to do this because they want that data also.
So that's just a quick closing question so we don't run out of time. We've talked a lot about the need for time, patience, and resources. I feel like the research that's been funded by the Bow Foundation until now lays a solid foundation from which other research can spring and grow. Being mindful of the recognition that y'all had to promote young researchers and young scientists to get in the field, where should we be focused on investing those finite resources if we choose to go beyond that, supporting doctoral candidates and students? From our perspective, we get 4 grant proposals, and they come in helter-skelter, and we got to choose between them which one makes sense, and we work with our doctors to do that. What is a proposal that kind of rises to the top in your eyes, and what's a proposal that warrants merit over another proposal? What are you looking for, I guess, as a scientific advisory committee to see reflected in a proposal that merits funding from the foundation? Better way to phrase the question?
I think one thing that would be helpful, as you say, they sort of come in helter-skelter and you have one at a time and you have to make a call. Is this okay or not? As opposed to having a call once or twice a year where you get in 4 or 5 of them, and then you can really look at them head to head and have a more, that's the way NIH does their grant panels. You're comparing them against each other and ranking them. Not that they do a good job with picking the best ones, but at least you have a way to do some comparisons. I think that would potentially be helpful rather than having it just completely open to have a call once or twice a year.
Thanks for that. Any other thoughts? Okay, well, we'll get back into the regular program. What we're going to do now is we're going to invite the families to stay here. We'll have a family track, and we'll invite the researchers to go have a conversation just around the table privately about potential for collaboration on GNAO1. So thank you all for being a part of this. We'll stand tight here, and we'll let the researchers take off.